Hello, good afternoon, ladies and gentlemen. I hope we are all doing well. All right, so it's exactly 4 o'clock. I hope you can all hear me.
Yes.
Okay, good. Yes, so my name is Benjamin Appiah. I'm the country manager for Hoffman Laboratories. So Hoffman Laboratories are the suppliers of the very popular Vivagest, which is present in over 22 countries. And God willing, we are going to launch Vivagest, or it's going to be present in most of the pharmacies in Ghana by close of the month. Today, we are happy to have one of our medical doctors who is a resident obstetrician gynecologist at the Cape Coast Teaching Hospital to take us through a very important topic. Pelvic inflammatory disease is a very important topic. It's one of the things that contribute to infertility. So without wasting my time, I'd like to invite our medical doctor in the person of Dr. Kwame Arhin to take us through this wonderful presentation. Thank you and enjoy yourself. So in the course of the presentation, if you have any question, you can kindly send it on the chat, or you can wait after the presentation, then you can ask your question. Thank you very much. So Dr. Arhin, kindly take over.
Thank you, Benjamin. As already stated, I'm Dr. Kwame Arhin. I'm an obstetrician, resident obstetrician gynecologist at Cape Coast Teaching Hospital. And this afternoon, we'll be talking about pelvic inflammatory diseases. Okay, so this will be the things that we'll be talking about: what pelvic inflammatory disease is, what are some of the causes, the risk factors, and when you come to the hospital, how we are able to come up with the diagnosis, and most importantly, how we'll be able to prevent this pelvic inflammatory disease and its sequelae. I hope I can be heard.
Yes, please,
Okay.
I can hear you.
All right. So, what is pelvic inflammatory disease? When we talk about pelvic inflammatory disease, it's an ascending infection of the female genital tract. Okay, and it involves the endometrium, fallopian tubes, and the ovaries, and sometimes the pelvic peritoneum. Okay, so there is a picture depicting the female genital tract, the upper female genital tract. So for pelvic inflammatory disease, the concern or the structures it affects is the upper genital tract. The vagina is not part when we are talking about pelvic inflammatory disease, and the cervix too is not part. Our concern is with the endometrium, the fallopian tube, and the ovaries as depicted in this picture. So they are the areas that are much affected when it comes to pelvic inflammatory diseases. So it is worth noting that pelvic inflammatory disease is kind of a sexually transmitted disease because that's the main route by which this infection comes about. And the organisms that are much implicated include Chlamydia trachomatis, which is the commonest organism that causes pelvic inflammatory disease. And the second most common cause is Neisseria gonorrhea. Okay, there are other organisms that cause pelvic inflammatory disease, but these two, Chlamydia trachomatis, Neisseria gonorrhea, they are the ones that are much more implicated when it comes to pelvic inflammatory disease. Okay, so when you look at the epidemiology in US, for instance, over 1 million women are treated with acute salpingitis. When we say salpingitis, it means that the fallopian tube, okay, so the fallopian tube, so when the fallopian tube is inflamed, that's when we call it salpingitis. So over 1 million women were treated with acute salpingitis, which is a component of pelvic inflammatory disease. And out of that 1 million, majority of them were below the age of 25. Okay, majority of them were below the age of 25. And as I stated earlier on, the route of spread mostly is sexually transmitted. Okay, there are a few instances whereby it spread hematogenously, as in the organism gets into the blood, and it's the patient or the client gets genital um, pelvic inflammatory disease, and that one is mostly as a result of tuberculosis. So in those instances whereby it spread hematogenously, the person may have tuberculosis of the lungs. Then due to some instances there is spread. So during the spread, it can get to the genital organ. So that's the only way that sometimes it spreads with the hematogenous route, which is very less common. Okay, the commonest route, as I've stated earlier on, is via sex or sexual intercourse. So in a large multi-center study by WHO, where more than 8,000 couples in 25 different countries were investigated for infertility, they realized that about 32% of the diagnoses were of tubal factor infertility. So pelvic inflammatory disease is very devastating when it comes to female infertility, as it's one of the commonest cause of female infertility. Hence, it's prudent that we know more about it, and so that we'll be able to take steps to prevent these mishappenings from happening to ourselves and to our loved ones. So let's talk about some of the risk factors when it comes to pelvic inflammatory disease. What are some of the risk factors? What are some of the things that will predispose a young woman to getting pelvic inflammatory disease? The first on my list is young age less than 25. At that age, the young female is adventurous and wants to explore in different areas. And hence, if such a young person is not guided to live an appropriate lifestyle, they tend to be promiscuous, and they tend to have multiple sexual relationships. Not that they have multiple sexual partners. They may enter into one sexual relationship, break up, enter another one. All these things predispose the young female to getting pelvic inflammatory disease. Then there are some females too who have multiple sexual partners. They are good players, okay? They are able to live with multiple sexual partners without being caught, okay? Engaging in sex with different people also predispose the female to getting pelvic inflammatory disease. Then commercial sex workers, they are so much exposed to these organisms, chlamydia, trachomatis, Neisseria, gonorrhea, and even sometimes HIV virus, okay? Then there is what we call early coitus. Coitus means that the first time that the female had sex, her first sexual experience. Okay, so if the female has sex between the ages of 10 to 19 years, that's early coitus. She has had sex too early, and that one predisposes her to getting pelvic inflammatory disease. You may say that it's not possible, but we've seen young females as young as 12 years getting pregnant. So it's something that is happening in our society, which we must take note. Then having unprotected sex, okay, that one too, you predispose yourself to getting pelvic inflammatory disease because you are exposed to all the organisms, chlamydia, trachomatis, Neisseria, gonorrhea, Gardnerella vaginalis. All the organisms will have their way with you if you have unprotected sex. Okay, then if the client has had a sexually transmitted infection before, anybody who's had a sexually transmitted infection before, either the female or the male partner, okay, such a person is at risk of developing pelvic inflammatory disease. Then also history of instrumentation. It could be that pregnancy was terminated using unsafe methods. Okay, unsafe method means that the place whereby the termination is occurring is not ideal. It's not at the hospital. It's not at a health center. maybe someone's home, someone's backyard, then it says it's terminating a pregnancy for you. It puts you at risk of developing pelvic inflammatory disease, because as the person inserts instruments into the vagina through the cervix, it opens the way for the organisms to ascend and move towards the endometrium, the fallopian tube, and the ovaries. Okay, so unsafe abortion is one of the risk factors that put females at risk of developing pelvic inflammatory diseases. Then some procedures, if a client goes for HSG as part of investigations for infertility, okay, because of the instrumentation that occurs there, most times after the procedure, the client is put on prophylactic antibiotics to prevent the client from getting pelvic inflammatory disease, because the procedure opens the way for the organisms to ascend. If the organisms are already in the genital tract, it opens the way for them to ascend and cause the pelvic inflammatory disease, the infection that we are talking about. Then in gynecology, any condition, if the person has had it before, the person is at risk of developing it again. So if the person has had pelvic inflammatory disease in the past, the person is at risk of developing pelvic inflammatory disease. All right. So these are some of the protective factors, the things that act as barriers, okay, to reduce the incidence or prevent pelvic inflammatory disease. Using barrier contraceptives, condoms, okay, it prevents the organism from getting into the female genital tract in the first place. So it's protective. Then pregnancy, okay, pelvic inflammatory disease can occur in pregnancy. However, it is rare. And even if it will occur, most times it occurs in the first trimester. That's less than 12 weeks, okay? And the reason why pregnancy is a protective factor is that when the female is pregnant, okay, as a result of hormonal changes, the increase in progesterone, it helps to thicken the cervical mucus. So when the organisms get into the genital tract, they are not able to ascend into the upper genital tract, including the endometrium, the fallopian tube, and the ovaries. Menopause plays a similar role. Then with the combined oral contraceptive pills, okay, one of their mechanisms also is to cause the cervical mucus to become thickened, hence reducing the influx of organisms like chlamydia and Neisseria gonorrhea from ascending into the upper genital tract. Okay. So pelvic inflammatory disease is something that we should all take note of, especially as females. Okay, it's one of the common OPD diagnosis that the females come in with, or clients come in with. Okay, and these are some of the features that you will see if a client is having pelvic inflammatory disease, especially a female in the reproductive age, which is the commonest age for a client to have PID. And from the epidemiology, we realize that those who are even less than 25 are more at risk. Okay. However, any female in the reproductive age coming in with abdominal pain, lower abdominal pain, one of the things that we have to think about as clinicians, okay, is pelvic inflammatory diseases. Then also, there are sometimes that they will come with vaginal discharge. Sometimes it's mucopurulent. Sometimes it's non-offensive, it's serous. Okay, it can come in with any form of vaginal discharge. You should have a high index for suspicion for pelvic inflammatory disease, because it sequelae can be very dangerous and can be very devastating. Then sometimes, okay, these females may have pain during sex, okay, during sexual intercourse. Sexual intercourse is something that's supposed to be enjoyed. It's something that supposed not to cause pain. So if during that period that you're supposed to enjoy, if you're having pain, then it should click that something is wrong. Something is wrong, and steps must be taken to remedy it. So they may come in with what we call dyspareunia. That's pain during sex. Pain during sex. And sometimes they may have this unusual bleeding from the vagina, okay, which is not so classical, but in instances like that, we should also think about pelvic inflammatory disease. Fever is one of the things when that's likely to occur in cases of inflammation, which pelvic inflammatory disease has some inflammatory component. Okay. All right. So in diagnosing pelvic inflammatory disease, okay, CDC criteria, they came up with what we call the minimum criteria and the additional criteria. So you need just one minimum criteria and two additional criteria to make a diagnosis of pelvic inflammatory disease. So the minimum criteria include lower abdominal tenderness, adnexal tenderness, and cervical motion tenderness. So the client has abdominal pain. When you examine the lower abdomen, the client is in severe pain, or the patient is in severe pain. It should give you a clue that it's likely to be PID. Then the adnexa, that's where the ovaries, the fallopian tubes are likely to be. Okay, when you examine and you palpate that area, you realize that the client is in so much pain. That one too should point towards the fact that this client is likely to have pelvic inflammatory disease. Then, in some instances, during the examination, the doctor is likely to do a pelvic examination. Okay, and the pelvic examination will mean that the doctor will put his or her 2 fingers inside the vagina, stimulates the cervix. Okay, that's the opening of the uterus. Okay, ideally it's not supposed to be painful, but if that elicitation, okay, causes pain, then you should think about pelvic inflammatory disease. So that's why such a client during sexual intercourse will have pain, because as a penis stimulates the cervix, okay, it tends to be painful as a result of the inflammatory process that is going on in the endometrium or the fallopian tube or in the ovaries. Okay, so with the additional criteria, you have temperature of more than 38 degrees Celsius when there is abnormal mucopurulent discharge. Okay, then increased ESR, increased ESR, there are laboratory findings, increased C-reactive proteins. Then when there is laboratory documentation of evidence of serial gonorrhea or chlamydia trachomatis, you should think about pelvic inflammatory disease. Diagnosing pelvic inflammatory disease is more of clinical than using ultrasound or any other investigation. It's more clinical than using the other modes of investigation. So concerning the diagnosis of pelvic inflammatory disease, as stated earlier on, it can be diagnosed clinically. However, the gold standard investigation for diagnosing PID is laparoscopy. Laparoscopy, it's a video that is able to look into the abdomen to see the structures there. So to be able to see if the tubes have become reddened. If the tubes are reddened, it means that inflammation is taking place and that this client may be having pelvic inflammatory disease. If the tubes have become dilated, they have become bigger than usual, then it may also point towards pelvic inflammatory disease. The other thing is that sometimes the video is able to see that there is pus around the tubes or even in the abdomen. It's pointing towards PID. Then sometimes the tubes, the ovaries, they increase in size, what we call tubal ovarian mass. Okay, so that one too points towards one of the laparoscopic findings that are consistent with pelvic inflammatory diseases. Other investigations that we'll do will include pelvic ultrasound to rule out other differentials. And remember, when a client presents with pelvic inflammatory disease, most times we take an endocervical swab for culture and sensitivity. And if the results come and truly it has cultured chlamydia or serial gonorrhea, and it gives us the specific antibiotics to use, we treat the patient accordingly. A lot of conditions can present as pelvic inflammatory disease, though. So don't just say that I have abdominal pain, so I have pelvic inflammatory disease. It may not be pelvic inflammatory disease. It may be other conditions such as an ectopic pregnancy, which can also present with abdominal pain, which can also present with adnexal pain because of where the ectopic is occurring. And these are conditions that can be very dangerous, and if care is not taken, you can lose your life as a result of that. So in such situations, when you're having any symptom, it's prudent, it's better that you visit a hospital so that you are seen by a doctor or a gynecologist so that you are treated accordingly. Even acute appendicitis, okay, where the pain is, it may look like pelvic inflammatory disease, but for all you know, it may also be an appendicitis. So these are the things that doctors think about. So it's not straightforward like that. When you are having symptoms, you're having signs, that some of the signs that we've talked about, still visit the hospital, let a doctor see, and let a doctor make that diagnosis of pelvic inflammatory disease after some of these differentials have been ruled out: ectopic pregnancy, acute appendicitis, sometimes even urinary tract infection, endometriosis, sometimes it's pain of unknown origin. Okay, so these are some of the differentials for pelvic inflammatory disease. All right. So concerning the management, the principle is to use broad-spectrum antibiotics that will cover chlamydia, trachomatis, Neisseria gonorrhea, and other anaerobic organisms. And it's recommended that treatment is started immediately diagnosis is made to prevent all the negative consequences of pelvic inflammatory disease, which we'll be looking at later in this presentation. Okay, and in stable clients, we tend to do OPD management with the antibiotics. However, after doing the OPD management and within 72 hours, you are not seeing any change in this client, you have to resort to inpatient management. So let's look at the criteria for inpatient management. What patients will we manage on OPD basis, and what patients are we likely to manage on outpatient basis? Okay, so concerning the inpatient management, if the client is an adolescent, it is prudent that the client is admitted and managed as an on inpatient basis, because PID or pelvic inflammatory disease, as we've discussed, okay, can cause inflammation of the tubes, okay, and the inflammation of the tubes can subsequently lead to tubular adhesions and tubular blockage, okay, which we learned earlier on that is one of the causes of female factor infertility, okay, and most times tubular blockage are due to pelvic inflammatory diseases that are poorly treated. So if an adolescent who has more reproductive years ahead of her is seen and diagnosed with PID, it is prudent and it's important that such a client is admitted and managed at the hospital. Then if the clients will not be compliant, okay, she will take the antibiotics today, the next day she's not going to take it, she's going to have difficult obeying instructions that has been given, then such a client will benefit from inpatient management, because poorly treated PID is tantamount to not treating at all. The effects are the same. Then if the client cannot tolerate oral medications, the client is vomiting, the client has nausea, then it's best that the client is admitted and given IV medication at the hospital. Then when the diagnosis is not certain, you are not sure, is this appendicitis, is this ectopic, the scenario is bizarre, okay? This client has lower abdominal pain, has adnexal tenderness, cervical motion tenderness, has fever. But remember, appendicitis can present similarly, ectopic can present similarly. So steps must be taken to rule out these other differentials. Okay, so if you are not certain of the differential, if you are not sure of the diagnosis as a clinician, then it's best that the patient is admitted, then you start management on the IV antibiotics as you still investigate to find out exactly what is causing the problems for this patient. And in situations whereby there is tubo-ovarian abscess, the client needs to be admitted and treated aggressively. Then clients with peritonitis needs to be admitted. Clients who are having high temperature of 38.5 degrees Celsius and above need to be admitted. Okay. So concerning the outpatient regimen, okay, there are several regimens. Different facilities have their protocols, but these are the ones that are commonly used at CCTs. This is what we use. Okay. The outpatient management, the client can be given a start dose of ceftriaxone, then continued on oral doxycycline and metronidazole. There are other regimens whereby the client is given oral ciprofloxacin, doxycycline 100 milligram for 14 days, then metronidazole. Remember that for antibiotics, they have to be prescribed by a doctor. You cannot just walk into the pharmacy and say you want antibiotics because you don't want any resistance in the future. All right. So concerning inpatient management too, we mostly resort to IV clindamycin, gentamicin. Then the client will be on the IV medications until we've seen that she has improved within 24 hours. If she has clinically improved within 24 hours and after 24 hours, then you can discharge and switch her to oral medications. All right. Then there are some situations whereby the client will need surgery. If there is tubo-ovarian abscess that is greater than 10 centimeters, you have to resort to surgery. Thus, there is pus in the tubes and the ovaries, and it has caused the tubes and the ovaries to become distended 10 centimeters or more. Then you have to resort to surgery to alleviate the problem. Then in situations whereby the abscess has ruptured, that one too is prudent that surgery is done. Then in cases of ascending peritonitis that does not respond to treatment, surgery can be resorted to. IUCD, it's one of the things that pose a risk for PID. Okay. However, the risk is highest within the first 3 weeks after the insertion. Okay, and if it's done under aseptic technique, the risk is very low. Okay, and if the client is having symptoms or signs of PID after the 3 weeks, some books also say 6 weeks. If it's occurring after that time, then you have to look for other reasons. But if it's within the first 3 weeks, then we are thinking that possibly is the IUCD that's causing it. And if it's a mild disease, it can be left in situ. Then you treat the client will be fine. Then still have her protection from pregnancy. Then in severe diseases, okay, in those instances, you may have to remove the IUCD and treat the patient. And even if you are keeping the IUCD, if after treatment within 48 to 72 hours, you are not seeing improvement, it's best that you remove it and treat the client. Okay. So the complications or the issues of pelvic inflammatory disease. Okay, the first on the list is tubo-ovarian abscess, which we've been talking about as the presentation went on. So the infection can progress and affects the tubes. Okay, and tubo-ovarian abscess can occur. Sometimes there is peritonitis as a result of peritoneal abscess. Okay, from the PID. Okay, so sometimes you can find even past the whole of the abdomen as a result of tubo-ovarian abscess rupturing and leaking abscess into the abdomen. And this one leads to peritonitis. And such instances, as we've spoken about earlier, needs to be managed surgically. Okay. Then sometimes PID causes chronic pelvic pain. Always this woman is complaining about pelvic pain, almost all the time. Okay. And these are some of the issues when it comes to PID. The client tends to have dysmenorrhea and all that as a result of pelvic inflammatory disease. And with the inflammation of the tubes, tuber adhesions occurring, it can lead to an ectopic pregnancy as the release of the ova will not be allowed to get into the endometrium since there is blockade. Hence, it can lead to an ectopic pregnancy, which can subsequently rupture, sometimes even cause mortality. Then, one thing that we all want is that after marriage, what most people are looking for is children. Okay, and as discussed earlier on, PID can lead to tuber blockade. Okay, can lead to the patient having both tubes blocked if the person has been having PID on several occasions, not properly treated or not treated, or okay, can lead to infertility. And even looking at it from the ectopic point of view, the client gets a ruptured ectopic as a complication of PID. There is a likelihood that the client can lose one tube. And if care is not taken, I've seen clients who are managed for ectopic pregnancy, then a year or sometimes even less than 6 months, they come back with another ectopic on the other tube. So it predisposes them to infertility. And in those instances, their only options would be to resort to assisted reproductive techniques. Okay. So PID is very expensive if it's not identified and treated. And then there is one rare complication, Vivagest syndrome. Okay, it's as a result of the inflammation that occurs, the peritonitis, the pus. So it leads to adhesion of the liver, okay, to the anterior abdominal wall. So the patient will be having right upper quadrant pain, okay, which is one of the symptoms of Vivagest syndrome. Sometimes, some rare scenarios, they may even have done this. Okay, so PID is something that we should all be careful about. We should all know about it. We should all take steps to prevent this gynecological condition. Okay, so the first thing that as a people, okay, we'll be able to take to prevent PID. You see, one of the risk factors was early coitus. Okay, we should increase education, sexual education, even at our basic level education, secondary level education. Let the young ones know that it pays to wait. Okay, it pays to wait. Saying no to sex at an early age or when you are not ready is one of the ways that you prevent a lot of gynecological issues, not just pelvic inflammatory disease, HIV infection, even cervical cancer, which maybe one day we'll talk about. And for clients or for women who cannot abstain due to one or two reasons, it is best that the barrier method is implemented, the use of the condom, so that the chlamydia, the Neisseria gonorrhea, they don't ascend and cause more damage. Okay, so abstinence is key. Education and health promotion And even to clients or to the females who cannot abstain, educating them about the use of condom is very important. Teaching them how to use the condom is very important, because someone may have the condom but may not use it the right way, and at the end of the day, the person will still be predisposed to getting pelvic inflammatory. Then being faithful to is one of the preventive measures, because if you are in a stable relationship and you think you are in a stable relationship, it's good to be faithful, because you not being faithful to your partner, getting other side chicks, getting other people for your sexual gratification, not only puts the female at risk, but the male too. Everybody is affected because it's sexually transmitted. So if you are not faithful and you're not using the barrier method of protection, then you are exposing yourself to getting this infection. And the purpose and reason for these programs is to educate the public, okay? And as we have learned today, we know the symptoms of pelvic inflammatory disease. So as a female in the reproductive age, if at any point in time you are having lower abdominal pain, you are having abnormal vaginal discharge, it is important that you report early to the clinic or see a doctor, so that the diagnosis can be made quickly and the treatment started immediately to prevent these complications. Then for the treatment of PID, I forgot to add that it's not just the female client that is treated, okay? So when the diagnosis is made, it is important that the male partner is also identified and treated, okay? It is important that the male partner is identified and treated. In some jurisdictions, contact tracing is even done for the partners, because for all you know, the other partner is having other partners that you are not aware of. So if you continue to have sex with that partner who has infected you with the infection, then treatment is going to be difficult. You're always going to be getting PID, is always going to be recurring. We'll put you on medications, we'll do IVs, you go back, then you come back again with the same symptoms because your partner has not been treated. And sometimes even if the partner is treated, the partner's other partners have not been traced to be treated, so it becomes a problem. All right. And all patients that we see with pelvic inflammatory disease should be offered full STI screening, and sometimes HIV screening too should be done as part of the management. And whilst the patient is being treated for pelvic inflammatory disease, you should try and avoid sexual intercourse until the patient and the partner have been completely treated. Okay, that's another way of preventing pelvic inflammatory disease. Then one other thing, I stated earlier on that unsafe abortion is one of the causes of pelvic inflammatory disease. And one of the ways to prevent unsafe abortion is to prevent unwanted pregnancies. And preventing unwanted pregnancies means that clients will have contraceptive methods, okay? Family planning methods should be available to females who do not want to get pregnant at a particular point in time, so that unwanted pregnancies will be avoided. Hence, unsafe abortions will not be done to cause all these complications that we talked about. Okay, pelvic inflammatory disease is one of the common female genital conditions, and its consequences are devastating. As we have learned today, prevention is always better than cure. So let's use this information and let's try as much as possible to educate others also. And whenever, as females, we have symptoms or anything, we shouldn't self-medicate. We should report to the hospital so that we are assessed by a clinician, a doctor. And when the diagnosis is made, we should try as much as possible to comply with treatment. Okay, prevention is always better than cure. Thank you. Thank you for your attention.
All right, thank you very much, Dr. Kwame Arhin, for this wonderful presentation. I think we all been educated by this presentation. So before we start with the question, those who are joining us, kindly check on the chat group. In case you're not part of our WhatsApp group and you want to join our WhatsApp group, kindly check on the chat and click the link and join our WhatsApp group. Okay, so I want to start with my question first. So I think you spoke about the fact that when ladies are being infected, it can also affect their partners. I wanted to check, does it come with the same name as in, I don't think probably it's called pelvic inflammatory disease, right? Does it come in a form of a different ailment, or to just the organism will just be there and males will not be affected, but just that they will just be transferring it to their partners, or it also comes a different form of disease?
So as I stated earlier on, it's sexually transmitted. So sexually transmitted infections like serial gonorrhea can affect the males too. So the males too, they may have some of the symptoms as discharge coming from the penis, sometimes pain during urination. Okay, that's dysuria. So the name is not PID in the male. Okay. So it can be urethritis, it can be gonococcal urethritis. So it's different. So in the male, it's sexually transmitted infection. Okay. But in the female, the pelvic inflammatory disease, okay, it's a combination of so it affects the endometrium, it affects the fallopian tubes, it affects the ovaries. So the constellation of all these things, that's what we call pelvic inflammatory disease. But if you are separating it, it could be endometritis, it could be salpingitis, it could be oophorytis. There are different conditions, but put together, it's called pelvic inflammatory disease.
All right, thank you. Yes, I'm okay. My second question is that does it always spread through the sexual organs, or you can get it even through by kissing, deep kissing?
So kissing, no. Kissing, no. It's mainly through penovaginal sex, because that's where the entry point for the endometrium is. That's where it will further ascend into the fallopian tubes and possibly the ovaries, then subsequently maybe into the abdomen. But for kissing, no.
All right, thank you very much. So questions have been open. So if you have any questions, just feel free and ask.
So
okay, somebody wanted to find out whether a virgin can get PID. I guess the answer is no, right?
yes, the answer is no.
Doc, please can you come again with the answer you gave?
Concerning a virgin getting pelvic inflammatory disease. So the answer is no. A virgin cannot get pelvic inflammatory disease. Like I stated earlier on, PID is more of sexually transmitted. So if you've not had sex, you've not had any unsafe abortion, there is less likelihood that you will have pelvic inflammatory disease.
Then I think the use of less likely actually
So no, you won't get PID if you are a virgin. Then there is some other thing causing the abdominal pain. Unless you are a secondary virgin.
I didn't get a second point. So unless you are hot.
No, that was on the lighter side.
Oh, okay. So we are still waiting for questions. So can you feel free and ask any question that is bothering you, please? Okay, so Regina, kindly ask your question. Can you unmute yourself and ask you?
Okay, so good evening. And Dr. Arhin, thank you for the wonderful presentation. I want to find out, in a monogamous relationship where the husband is faithful and then the woman are faithful, but the woman keep having recurrent vaginal discharge, is treated and she gets it again, both are treated and she keeps getting it, what could be the cause then?
So the commonest cause of vaginal discharge is actually bacterial vaginosis, okay, which is not sexually transmitted. It's not every vaginal discharge that is pelvic inflammatory. There are a number of things that can also cause vaginal discharge. One of them, as I've stated earlier on, is bacterial vaginosis. Can have candidiasis, and even sometimes it's physiological. So it's important that such a client be evaluated through with samples of the discharge taken for culture and sensitivity, so that based on the organism that is cultured and based on the antibiotics that are sensitive to that organism, the woman is treated properly.
Oh, okay. Thank you very much.
So,
okay, thank you. Veronica, kindly come in and ask your question. Veronica, can you unmute yourself and ask the question? I can see your hand.
Hello, good evening. Please, my question is, can an infected person with a PID transmit the PID to another person using the same washroom with them?
oh, okay. So concerning the hello.
I
Concerning the
I can hear
washroom issue, no.
Okay.
It's more of sexually transmitted. Like I stated earlier on, it's an ascending infection of the female genital tract. Okay. So
Okay.
there has to be a break in the barrier for the organisms to ascend. So using the same washroom is not a means whereby a client or a woman will get pelvic inflammatory disease.
Okay. Thank you.
All right.
Okay. Any other question, please? Okay, I can see some questions on the chat room. Okay, so somebody wanted to find out can I know the differential diagnosis for PID?
Okay, all right. We talked about it in the slide. So the differential diagnosis, as we discussed earlier on, can be acute appendicitis, ectopic pregnancy, urinary tract infection, endometriosis. All these are differentials for PID. Differentials means that there are other things that present like pelvic inflammatory disease, but they are not pelvic inflammatory disease. So meaning ectopic can present like that, acute appendicitis can present like that, UTI, endometriosis, ovarian rupture, ovarian torsion can all present like PID. Okay.
Okay. Okay, there's another question here. What about the cramps you feel 2 days before you had your menstrual period? Is it PID? Or is it in line with PID?
Okay. And after the menses, or during the menses, it's resolved. So it's not PID. For the dysmenorrhea that comes with PID, most times it occurs alongside during the menses. The pains are so unbearable. It's very severe. It's not the ones that come prior to the menstrual period and resolves. Okay. So the ones that are in line with PID, most times it occurs during the menstrual period as well. Are we okay?
Okay. Yes.
So the next question.
Okay, Regina, can I ask? I think your hands is up, so if you can ask.
Okay, please, I wanted to find out with regards to the IUD insertion related PID. Can you please go back to that again? I think it had to do with if somebody has an IUD inserted and then within the first 3 weeks
Okay.
they have an infection, then probably it's as a result of the IUD.
Yes.
In a case where it's after 6 months,
After
6 months, and then the
Okay.
person had an infection, it was treated, and then now the infection keeps reoccurring.
Okay.
It's the same partner too. The partner too was treated as well. So how do we go back with that?
Okay, so this one is not occurring in the first 3 weeks. It's occurring after 6 months after you've inserted the IUD, right?
Yes, please.
Okay. So the recommendation is to treat as you treat any other individual without removing the IUD, since that is not the primary cause of the PID as at that time. Hence, we treat, if it's OPD basis, we treat as such. However, in severe diseases, okay, if you are treating and still you are not getting improvement, okay, it's recommended that you remove it and you treat. Then you get other forms of contraceptive method, because when you remove it, the client is likely to also get pregnant. So you have to think about that one too also.
Okay. Okay. Thank you.
Can fibroids also cause abdominal pain? Yes, fibroids can also cause abdominal pain. Okay, and they cause abdominal pain. Fibroids can undergo some changes, what we call degeneration. Okay, so when those changes are occurring, it can give the client abdominal pain. Then there are some fibroids too that are pedunculated, as in they are held by a stalk on the uterus. So when they twist, that one too can lead to abdominal pain. Okay, so fibroids too can cause abdominal. Hello.
Hello. Yeah. So I think there are some other questions. Veronica, I still see your hands. I don't know whether you still want to ask any question.
No,
Oh, you're
please.
okay.
It's your old hand. Yes, please.
Oh,
Thank
okay,
you.
okay. All right. So, Doug, I can see some other questions on the chat. I
Okay.
don't know whether it's possible for you to read them.
Okay. So one question said, I would like to find out what's link has PID with the pouch of Douglas? Is the diagnosis positive if there is fluid in the pouch of Douglas? If there is none, does it mean it's been treated? So fluid in the pouch of Douglas does not mean that a client has PID. There is always, most of the time, there's fluid in the pouch of Douglas. Okay. So if you find fluid in the pouch of Douglas, it's nothing. It doesn't point towards PID or anything. Okay. There are instances whereby the client may have ectopic, whereby there is structure, there is so much fluid in the abdomen. That one, you're likely to find massive fluid in the pouch of Douglas, because if there is hemoperitoneum or blood or a lot of fluid in the abdomen, they will try to find the places whereby there are space so that they will collect over there. So in those instances, then you are making a diagnosis of an ectopic pregnancy. But if you go and do a scan routine and they say there is minimal fluid in the pouch of Douglas, so you have PID, it's a no. PID, as I said, the diagnosis is more clinical than using investigations. And the investigation of choice or the gold standard is the use of laparoscopy. So if it's not laparoscopy, then you are better off being diagnosed clinically than a sonographer using an ultrasound to diagnose PID. Okay. Yes. The diagnosis of PID, we talked about it during the presentation. The clinical features that the client may present with vaginal discharge, the client may have lower abdominal pain. We talked about the minimum criteria and the additional criteria, whereby the minimum criteria there's lower abdominal tenderness and axial tenderness. Then when the doctor examines you, he feels that with a little movement of your cervix, you feel pain, what we call cervical motion tenderness. All these are pointers towards PID. Then sometimes there is fever. Then when we do the culture and it comes back that there is Neisseria gonorrhea or chlamydia trachomatis, all these are pointers towards pelvic inflammatory disease. But every female of reproductive age coming with lower abdominal pain, they have to think about pelvic inflammatory disease. And it's important to make the diagnosis early, start treatment early to prevent the negative consequences like the tubal ovarian abscess, the severe abdominal pain as a result of peritonitis, the consequences of infertility, having to go through fertility treatment, expensive artificial reproductive techniques and all that. So it's important that we understand PID. It's important that when we see signs and symptoms, we report early and we are managed early. Okay, all right.
Yes. Hello.
Hello.
Okay, I wanted to be sure that I'm audible. Okay. Yeah, so if there are no other question, then probably
Hello.
Kindly check on the chat into kindly so that I can get most update at a very faster rate. This presentation was brought to you by Vivagest. Vivagest is a super supplement for pregnancy. It is taken from preconception to breastfeeding. Anybody that desires to get pregnant, it is very important that when Vivagest is launched in Ghana, you take some, not just take it before the pregnancy, but you take it from pregnancy to pregnancy to breast. Next week, go with cervical cancer. I think doctor was he was in the spirit to say that you'll be coming very soon. That is happening next week. So next, I bring in doctors, medical doctors. They are the founder and co-founder of organization called Cervical Foundation Ghana. So they'll be in to give us a presentation on cervical cancer. But next week we're having it at 7 p.m. I think most of the time we have it at 4, but next week is going to be at 7 p.m. So apologies, kindly try and join us at 7 p.m. next week. We'll be sharing the links to our various platform, social media platform, Facebook, Instagram, and of course our private WhatsApp group. Meet us at 7 p.m. at the same time. Thank you very much, Doctor. Thank you so much, audience, for joining us. I know most of you people have a lot of things doing, but decided to join us. So we are so grateful. So kindly let's meet, God willing, next week at 7 p.m. for another wonderful presentation on cervical cancer. Thank you. God bless you. And those who are Christians, please go to check tomorrow and enjoy the rest of the weekend. Thank you very much. Bye-bye.
Bye. Bye.